Welcome back. If I can have the CEPAC take their seats too. CEPAC, if you guys have a comment or a question, I will try to pivot every once in a while and make sure I appear back here. Put your tent cards up and we can take a look. Thank you. So we have a very diverse panel, but I know we never do justice, honestly, to the diversity of the patient population. We don't have an African-American part of the meeting today. That's unfortunate. There are people from different parts of the country who probably experience the diabetes care system very differently. But we'll try to capture some of that in our discussion going forward now. So what we do, again, in the Policy Roundtable is try to pivot from the discussion of the evidence itself to talk about the delivery system. And that includes everything from how patients are educated and contribute to the care process, to how clinical experts and their guidelines are informed by the evidence, to how payers look at this information and factor it into their pricing negotiations and formulary design. And for manufacturers, there's also obviously a pricing issue that's often on the table, as well as thoughts about future research and how we can make sure that it tries to fill in the gaps and the uncertainties that are always what we're grappling with at this phase anyway. So thank you all for participating. Why don't we just have everybody who's new to the panel briefly introduce yourself. We'll start down with Bill and just kind of name and which organization you work for and in what role.
Right. I'm Bill McQuaid. I'm the Senior Health Policy Analyst with the Rhode Island Medicaid Program.
Good afternoon. Jeff Kasberg with IPD Analytics. Been in managed care pharmacy for about 25 years.
Hi, good afternoon. Dave Strutton from Merck. I'm with the Center for Observational Real-World Evidence.
Bonnie Donato, Boehringer Ingelheim. I'm in the Health Economics Outcomes Research Group.
And we know Todd. All right. So thank you again, by the way, to all of the manufacturers for participating all the way through the review and up to and including this meeting. And just so you guys know, Jeff, IPD Analytics is here in a sense representing knowledge of the payer community. IPD Analytics is not a payer, not an insurer, but they do a lot of evidence review and looking at coverage policies across the entire country. And so we thought it'd be helpful and interesting to have him here in some ways to reflect on the variation of coverage policies and what we can learn just from the ways that health plans, again, from his perspective, are translating the evidence into different kinds of approaches. But first, let's start with the patient again. So we have talked a lot, and I think that's good, about the fact that this is a pill, right? The first pill in its class. And that patients and doctors in any kind of condition, especially when there's a huge variety and diversity of patients' lived experiences with type 2 diabetes, it's good to have lots of different options. Is there anything else about having a pill now come to market in this class that we haven't talked about from the patient perspective? You mentioned a little bit about how the education needs to be careful not to edge onto insulin is the bad actor here, and we're just trying to do everything we can to keep you away from evil insulin. Say anything more about what you think we should take away as a recommendation about the way that this is messaged to patients and families as they have a new option to consider.
Thank you. While we don't always realize it as clinicians, there is a power differential that does exist between clinicians and people who come in to see clinicians. And often people who have been diagnosed with type 2 diabetes feel judged and want to please. So they may not always be open in answers, especially if the questions are not posed in an open-ended way. If they're just yes or no questions, or if the clinician is kind of rushing too much, or even if the body language, I've already spoken a little bit about language, but even if the body language is not there, I feel that people with type 2 diabetes may not make their needs known as much about switching medications, going to a pill, forget that the pill is larger or when it may need to be taken. And with any injectable medication, going back to if it's a warning. If you don't lose 10 pounds next time you come in and you don't start exercising and you don't start sleeping more, oh yeah, I'll fit that in, and also quit smoking and stop drinking at the same time and get all this done, you will, with the finger wagging, need to be on more medication or need to get a needle. So I think we need to recognize that even though we don't mean it, and we want to be fixers, that power differential does exist, and anything we can do in terms of language, finding out where the person is on their diabetes journey. The other piece I wanted to mention is that, of course, treatment plans are going to change with diabetes, not only throughout the lifespan, but with different things come up. There could be a change in job status that affects your health insurance. Young people at 26 go off health plans, things of that sort. So just take a look and see really what's going on individually. Person-centered approach.
Sounds good. Clinical experts, that's what you do every day, right? All doctors do it that way? How will this be woven? Comment on that, but also as because it obviously influences insurers a lot what's in the clinical guidelines from authoritative groups. And maybe comment on where new oral agents will fit in the current algorithms of care, either your own personally or the kind of the societal guideline, the society guidelines. What does the advent of semaglutide mean for all of that?
I think for an endocrinologist, again, I'd like to separate how endocrinologists think versus primary care. When I have a patient, I think what is the next best treatment for him? Is it which class suits him better? And then after the class, I start deciding is it has to be oral or injectable. As a primary care, it's different. They want to think if it's oral first or injectable. Second, when we talk about guidelines, so you have ADA guidelines that tells you go metformin first, and then second line you go based on, you decide you look at cardiovascular risk, heart failure, kidney, cost, weight, hypoglycemia, and you make your decision. The European Society of Cardiology has moved up the GLP-1 and SGLT2 up in the algorithm, and they said patients who have very high risk of cardiovascular disease or patients with cardiovascular disease can go on SGLT2 and GLP-1 first. So this is the first guideline that have moved that. We don't know. We don't think this will happen with ADA because it's going to be hard to prove that those medications have this benefit without background of metformin. Keeping in mind that all the studies have used metformin, 70 to 80% of metformin is used as background therapy. Mm-hmm. So in my mind, after metformin, I do think, the ADA has its algorithm, but I think similarly, the only difference that I use myself in my clinic is I actually take eGFR into account. Because for me, of course, every aspect that ADA mentioned is important, but at the end, I could care about heart failure, but if the eGFR doesn't allow me to use a drug that is good for heart failure, I'm not going to be able to use it. So for me, my own algorithm, I look at eGFR, and if it's less than 30, there's only one or two options, which are insulin and maybe one DPP-4 inhibitor, as of looking at the label as well, not things off-label, of course. 30 to 45, I can use GLP-1 receptor agonists and so on. And then I look at if I have to decide between oral or injectable based on patient preference and so on. Mm-hmm. Again, I emphasize that primary care is different. They have to see what is more convenient to them and to the patient. So
basically, in the society guidelines, semaglutide just goes into the bucket with other GLP-1s, and it's a good thing because it offers another delivery mechanism, but otherwise it's not going to make any changes to the way that the
currently
general
the guidelines at the state, yes, the ADA just says if you go correct, you go with metformin, and then you add on based on those benefit.
And do you think that the guidelines, forgive my ignorance on this one, I should have looked before the meeting, but the choice between a GLP-1 and an SGLT2, which we'll spend a fair amount of time talking about, now that there's an oral GLP-1, how much of a issue will the guidelines make of that, or will it be kind of not that big a deal? Or because right now, my understanding, most guidelines just basically say they leave it up to the clinician. You can go GLP-1 or SGLT2 or whatever. But is this going to make any kind of a difference in the way that clinicians weigh the choices? You said clinically what's best for this patient, an SGLT2 or a GLP-1. Is this really not going to change that equation very much?
I mean, we'll see how it affects guidelines. I think as an endocrinologist, and for me, it's the class It's not about the form of the media. That's why I think it's going to be a big push for ADA. Of course, there's other guidelines, but there's other guidelines that says injectable, for example. But it's going to be kind of a little bit hard to say, oh, now use oral just because it's an oral form. For me, it's a class. Now, talking about other guidelines, like for primary care, maybe it might be easier to move this in the ladder up in the algorithm to use it first because it's an oral. I wouldn't know how it would affect, but it might penetrate easier to penetrate. But similar, as I said, we have seen it with the European Society of Cardiology, not because it's oral, but it really has moved up as first line of treatment. So now that you have a drug that is oral with cardiovascular benefit, weight loss benefit, and so on, and knowing that metformin is not that much tolerated by patients, whether there's a guidelines or not, you just put patients on metformin for like 4 weeks, and then you can just say didn't tolerate, and people are going to move up quickly to orals.
We'll see what the insurers think of that.
We have seen the experience in the past, how DPP-4 penetrated the market real quick. I think if I have to predict, once primary care gets used to this, they're going to use oral same as the DPP-4 use, once they really get the handle of how to, familiar with it and how to prescribe it.
David, I may still call you in here every once in a while. But Lisa, what's your perspective on how this is going to influence the thinking around the guidelines?
Yeah, well, stepping back for just a second on the guidelines, I think people who've certainly been on guideline panels, but most people realize guidelines are, one, very political, right? So
really?
I think it's always, there was some comment about thinking about guidelines in this discussion. I think this discussion is what should inform guidelines rather than the other way around, right? And so I love the rigor of ICER that is the facts and nothing but the facts, as you think about that, which can then inform guidelines, which have to, in the absence of full facts, decide what to do. So there's a lag, obviously, as well. I don't think I very much agree with what's said. I think that oral versus not, the guidelines will stick more with the class of drug. So I don't think it's going to be just because there's an oral agent, oh, you must now change your guidelines to have a preference for the GLP-1s. So I don't think it will have a big impact there. I do think it'll have a big impact in people trying GLP-1s, and I think our primary care providers, again, I think they're not going to write their own guidelines. I think they come to endocrinologists to write the guidelines, and very much do try and follow what is out there. I think, unlike the DPP-4s, because of the significant GI side effects, some primary care providers may be more quickly turned off by the drugs than the DPP-4s, because they're a drug that you could give, didn't lower A1C much, but it didn't cause any problems, and so you just add it on and you keep it on forever. And so then they keep using it because they haven't had problems using it. I think that's one of the big successes, and you might not see the same with these drugs. But I think ultimately it'll be the patient choice, and I think it's valuable when you go to that patient. You want a once-a-week injection, or here's a pill if you really hate injections. And at the patient level, I think it will make a difference to have this as an option. I think that's very important.
David, why don't I give you a chance to comment, since this is right up your alley. Thinking also, we haven't talked to the folks at ACP or others who might also have guidelines around, but they'll defer to the endocrinologist.
And metformin is still a really, really good drug. There's cardiovascular and mortality data from UKPDS. I'll just make sure that's out there.
So David, reflect again. I mean, you may have even heard people talking about it already in terms of it's coming. Let's line the patients up out the door. Time to get them started on the new oral GLP-1. What do you think the primary care view of this will be?
Yeah, I think that the GLP-1s haven't been used as much by primary care doctors as they would have been if they were oral. That we have the ability to teach people to do injections, but it's a big deal to do that, and lots of patients, people don't like taking medications for asymptomatic conditions. They don't like taking statins, which are way easier. So having an oral, I think this is going to be used a ton. I think people are going to start picking this. It is true that giving twice in a row, first metformin and then oral semaglutide, and twice making people nauseated as you're going up on the doses, is going to be a problem, but I don't think it's such a problem that we won't try. We really try to push metformin, and I think we're going to end up trying to push oral semaglutide.
Okay, interesting. One question I'd like you also to comment on.
Can I add one
Oh,
thing?
sure. Why don't you do that
Sorry,
quickly,
yes,
and then
so
we'll let.
I think very good points by David, and we have some data that clearly shows that 100,000 of the primary care physicians we work with and sample, out of those, around half are comfortable with injectable GLP-1. They're using it. They're using basal insulin. They have maybe resources. Half of those do not write GLP-1s at all. And there's many reasons for that. Patients don't want it. Yes, we talked about that. Cost could be. But those are the ones we hope that will now at least be more comfortable with the benefits of a GLP-1. They'll start to incorporate it some in their interpretation of the algorithm, how they do that. And those are the ones we think we really want to work on, that they're not, none of their patients are experiencing a GLP-1 product at this point. So we don't think those are already comfortable with injectable semaglutide or other injectable GLP-1s are going to change their practice habits, and they're used to that. It's the ones that have really not embraced GLP-1s at all.
So the opportunity is half of the primary care doctors in the United States?
We really are not writing. And until the weekly GLP-1s came about, the GLP-1 marketplace was not flat, but not growing very much. And the weeklies changed that to some extent, but we're still less than 10% of all new diabetes scripts.
So I'll turn back to the clinical experts now, too. Thank you. Because one of the things we try to put in some perspective in the final version of our report is not the anticipated clinical use necessarily, but kind of, in some ways, what do you envision as the ideal use of this as a market share, even, to a certain extent? We're trying to figure out, is bringing this into the market going to bring new people into treatment that weren't treated before? Is it an add-on, and therefore, from a budgetary perspective, an added cost? Or is it just cannibalizing people who would have taken a different SGLT2 or an injectable instead? Where do you think the niche for this is, and how many patients at a certain point in their care process will be started on this drug that represent, in a sense, a new treatment?
I can't give an exact number, but based on the two things that we've heard, I think certainly a lot of patients will be tried on it. And I think there is definitely, for the cardiovascular benefit, a real role for these drugs. And so if they're being underutilized, that's a good thing. How many of them stay on it, I don't know.
Okay. What do you think, Joanna?
I see it is going to pick up, I'll start by the easiest. Cardiologists are going to pick up on oral GLP-1. That's going to be easy. I think I agree with Todd that primary care are going to decide what's the next line of therapy, and they're going to pick on oral sema as now, I think right now they have DPP-4 and SGLT2 in use. I think they might add it to SGLT2. They're not going to replace. I don't think they're going to replace injectable either. They will add it to either they will replace DPP-4 if they think patient need additional benefit, whether A1C or other benefits, or they will add it to SGLT2 because more likely they are going to be on SGLT2 inhibitors. If they are not on SGLT2 inhibitor, I think they're going to have to decide, is my next option an SGLT2 or an oral GLP-1. Right. That's for primary care. For endocrinologists, as I said, I don't think it's going to matter. As soon as oral sema came out, my discussion has remained the same. If I'm thinking of GLP-1, I just tell them you have once a day, once a week injection, or once a day pill. It's still the same in my mind. GLP-1 next, then these are your three options, and I discuss that with the patient. I think the more uptake is going to be by primary care and cardiologists. Yeah.
It is interesting, isn't it, how many chronic diseases over the past 20 years have gone from a single drug to treat it to multi-drug regimens. It's just, it's really interesting how often that's happening. We had a meeting recently on cardiovascular disease with fish oil and other, things coming in. We were talking then about the pill burden on patients, many of whom have the same overlapping set of kind of cardiac risk factors, with diabetes being a chief one. So it's another issue that primary care and endocrinologists will face. So let me ask a couple questions of the manufacturers, if you don't mind. So Dave, you make sitagliptin, right? So the DPP-4s, it seems like we heard, why primary care likes to use them. In some cases, it seems like they're the poor cousin. Everybody says, well, they're not as effective with hemoglobin A1C. They're much cheaper. What's their role in therapy? What do you guys view as the ongoing role for DPP-4s as other oral options come into the market?
Yeah, I guess that remains to be seen. It's it's obviously a very interesting time within the diabetes space, particularly with the DPP-4s having been such an important component of care for such a long period of time. It'll also be interesting to see how that changes as the sort of the LOE time for the DPP-4 class approaches, and how the potential combination therapies with SGLT2s and through the various stages of care. But I don't, we don't have a very clear vision of exactly how that will manifest. I'd be interested to hear from our clinicians on the panel of how they envision this class evolving, or the use of the class evolving.
Steve, I'm sorry, it's Brian.
Brian,
over here. Behind you.
Jeez, that scared the heck out of me. All right.
David
Who's Brian? I'm going, where's Brian?
I think David brought up a point. I think you were bringing up this point. And when are some of these older drugs coming off patent? Because obviously that makes a huge impact on cost and what's available through insurers and to patients who are paying out of pocket. So I don't have a sense of when any of these are coming off patent.
Yeah, so on the DPP-4 side, Januvia looks to be approximately June of 2024. That's what my organization is predicting right now. On the SGLT2 side, I think Farxiga would be the first to lose exclusivity, I think 2025-ish.
Still a ways.
So still a ways, yeah. So that's DPP-4, SGLT2, and then so we have Victoza was the first, well, not the first, Byetta was first, but the real first one that was utilized on the GLP-1 side, and Victoza also 2024.
Thank you.
Good question. Is there an easy, quick answer to the future of DPP-4s?
I don't think they're going to disappear anywhere. This is like an easy drug. Even there are hospitals, I would say, where are using, at least where I worked, in the 2 hospitals I worked, is the only drug that was able to get to formulary easier compared to others. And you can start it as an inpatient. You don't have to get concerned with SGLT2 and DKA or even metformin and other things. So I think DPP-4, regardless of how poor you're rated on A1C or other outcome, is not going to go away, especially when go off patent is going to continue. I don't see it.
Okay. Susan?
I mean, with primary care especially.
Yeah.
I agree too, even if other parameters change, if people are currently comfortable with the medication they're taking and there's no new things, complications, changes coming up, they will stay with what they're currently using. Comfort level.
So Jeff, let me ask you at this point, how, given the current complexity, before semaglutide even enters the picture, what's your understanding of the variation in the way that payers are covering diabetes drugs? How many of them are using step therapy? How many of them have really strict criteria for things we'll talk about metformin use before jumping to these things? Are there means and medians in these approaches, or is it just a complete wide open variation in how these things are done? What do you see when you look at coverage policies?
So currently, it's pretty interesting when you look at the different therapeutic classes. You have CGRPs at $6,000. Everybody's managing them. PCSK9s came from $12,000, $14,000 down to $6,000, still being managed. And then you have the CGRPs at $10,000, and really, they're not being managed. When you hear step therapy right now in diabetes, it really means metformin first. And that's really a given anyway. So it's a step, but not so much. I think where we're going is potential management here. Before this meeting, I did a little preparation and tried to review the top PBMs and large payers across the country. And currently, it's pretty interesting. We're in mid-November, and usually the payers announce their coverage, before the new formularies come out. And you really don't see Rybelsus listed a lot yet. There is one large payer who has listed their current policy. And so I kind of see the drug moving forward being managed in 3 ways. This one large payer, Anthem, currently lists it as one step. and that would be a step behind their currently preferred GLP-1s. And that,
Wait, can you clarify that? You mean they would have to go, when you say one step, you mean metformin and then an
So
injectable GLP-1?
from their publicly available information online, it looks as though they're requiring their preferred GLP-1.
Yes.
If a doctor would like to use the product, they have to go through an injectable GLP-1 to get to Rybelsus. And that kind of makes sense. The payers are concerned about cost, a lot of additional use from PCPs, and if you put the preferred injectables first, Rybelsus second, that kind of, to some degree, solves that problem. So that's one way to manage the drug. Payers could stay the way they are now and just have a MET step that really opens the door up for PCP use of this product significantly. Or there could be more traditional type steps where the payers could say, well, use the SGLT2 or DPP4 first prior to a GLP-1. And that makes sense from a, we could argue clinical makes sense clinically. The SGLT2's excellent clinical data, especially recently, more and more strong evidence of their favorable outcomes and advantages. So have people go through SGLT2, then to a GLP-1. And that's not really been done yet in the United States.
Sorry, so I thought you were saying it is being done, the SGLT2 first.
Right now, there's really not too many plans with steps on the GLP-1s.
Just once you get through metformin, it's basically unmanaged.
Open season.
Open season, okay. But they must have preferred agents within each class.
They do, yeah.
Which vary a lot, I'm
right.
sure.
But you get to that, you can get a product in a class.
Right. Okay.
But if they, if the payers would put the step in front of the GLP-1s,
yeah, that
would be a change.
All right. Well, let me come back to that issue and just reflect back with the clinical experts. What do you think of the idea of stepping through an injectable GLP-1 to get to the oral version? Does that make sense?
It doesn't make sense to me, but...
If you're a pharmacy manager, it makes a lot of sense. Yeah, I mean, I think the whole reason is, what I'm thinking in my head is you're going to then have to say patient won't do injections, and that's why I need the oral. So it's a little harder to fail the injections. So I'm envisioning, do they just not do the injections? You prescribe it and they don't fill it, and then that's the failure? Because I can't see any other advantage other than the patient. So I don't know what the step therapy would be. I mean, it's obviously an excellent barrier for all the reasons he said.
Bill, did you take a look at your guys' diabetes coverage before today's meeting? Curious.
I spoke with our medical director.
Yeah.
But actually I've been confused more than once in the last 5 minutes with all the terms that are being thrown about here. So I'm not really sure I can talk cogently about our step therapies and what and how they're affected. But also I think Rhode Island is a little different. I'm a health policy analyst with the Rhode Island Medicaid program, and Medicaid is primarily a managed care thing. So we have contracts with 3 health plans, managed care companies that provide care. So our role in this, and even my interest in this discussion, is we want to be sure that the health plans are providing an appropriate array of treatments for our patients, and that they're not nickel and diming patients to save money and that kind of stuff. So what I'm thinking about this is, does this belong on a formulary, and does this belong as one of the steps in the process? Right. And are our managed care companies managing diabetes in an appropriate manner? So,
all right. I want to work maybe our way back up to the question of SGLT2 step before you get to GLP-1, since that's not being done right now, but you say you could envision it possibly being done, especially if the cost difference is important enough. Let's go back just to the first step, perhaps metformin, because in some other clinical areas, like statins, to get to PCSK9s, there's been a huge kind of fight over what statin intolerance means and how you define it from a coverage policy and from a clinical perspective. So for metformin as the first step to get to these other drugs, are there any coverage policies where you have to show I've been on X number of months of metformin with a hemoglobin A1C that's still too high, document that before you can get a GLP-1 or an SGLT2? Or is it generally left just up to the clinician's discretion or maybe there's not even any prior auth on getting that first GLP-1 or SGLT2. What's been your experience clinically with that?
My experience that insurance have preference on which GLP-1, but I think never had any rejection on a GLP-1 on any of my patients.
So you don't have to document use of metformin?
I don't even remember the last time I put prior auth for GLP-1.
Okay.
I don't know. I don't remember. I've put that recently. I mean,
okay. Interesting. Lisa, are you familiar with that?
Yeah, I think we've been so successful with metformin being universally used. I don't know that it, I feel like it is, yeah, I haven't ever had to do that, but I can't definitively say that it's not in the rules.
Okay. And Jeff, any idea whether any insurers do much with the metformin part of this or not?
If you scour the prior authorization guidelines, you might find a 1 or 2 month requirement, but it's more of a checkbox, and that it's used almost universally first line anyways.
Right,
it's almost a pass through, so the met step is invisible in many cases.
Okay. Yes, Greg. And please remind people what your day job is.
Yeah, my day job is I'm the director of the Mass General Physician Organization's pharmacy program. So I deal a lot with the primary care physicians, and I think these product preference limitations have given the primary care doctors I've interacted with this belief that they will never get the product approved. So they almost feel like they have to do the specialist referral because they might be comfortable with one GLP-1, that gets rejected, they throw up their hands and they say, I guess I have to always refer these to specialists. So it's almost like they're all ground-tied horses now. They just believe they can't get these products.
And that's because they get their GLP-1s rejected?
Because of product preference, not because of
because
the
of
step
product
therapy.
preference, okay.
Yeah.
Well, that sounds almost more of a failure of the insurer or the system to get the information down to the doctor level than vice versa. Yeah, that's interesting.
But we have to keep in mind that also those change throughout the year. It's not like they are, at the beginning of the year they are on one GLP-1, and then in the middle of the year you have to switch 2 or 3 other from their medications.
Susan, you have something to say about that? Yes.
No, it wasn't just about that. I also want to point out that prescribers are not only endocrinologists and primary care providers, they're also nurse practitioners, PAs, physician's assistants, and other providers do write prescriptions. So I'm not exactly sure, like after a lot of the people that I work with in my practice, and I'm not affiliated with a hospital, I'm in private practice, so people do refer to me, so it's, I guess, a little bit unique in that way. But once people are seen by an endocrinologist or even a primary care physician, many times the next time they come in for follow-up is with a nurse practitioner or a physician's assistant, and they sometimes make some of the changes that come on. Now, I'm not saying if it's not a big change, they don't have to go and speak to others on the team to get approval, but they do have some decision-making, so I want to make sure that's not overlooked in this discussion.
Okay. But it is interesting because just in the general chatter that you hear where doctors are most upset with the barriers through prior auth and step therapy, you don't usually hear about it in diabetes. You hear about it a lot in the autoimmune space and some others perhaps, but you don't hear it that much in diabetes. Am I wrong? Do you guys talk to each other a lot about the barriers that you find? I mean, it sounds like, well, when you have to switch your GLP-1 every 4 months, maybe that's...
No, we do good. We do
I triggered
pretty
something
much
here,
a lot
so
of
tell me.
prior authority. We do a lot of paperwork. It's I'm not going to. I just don't think I recently put any for the GLP-1 recently, but I don't know how things have changed. We do go through a lot. I mean, all the maybe not GLP-1. We do PCSK9. A lot of. I think sometimes Medicare and Mass Health do request that you have used metformin without any specific time.
Right.
But certain time, I think private insurance payers, I don't think they have recently put, you just have to pick with GLP-1 or SGLT2. Right. I think you're right. Maybe all the paperwork are related to technology now that I'm thinking more, less of the burden of the GLP-1 and SGLT2.
Yeah. If I had to guess, though, if I had to predict, hearing what's going on in Europe with their guidelines, where they're moving to skipping right past metformin to more expensive
Those
drugs.
are the cardiology guidelines.
Cardiology guidelines. There's a guideline on the table somewhere that suggests that I predict someday, not in the too distant future, insurers are going to start to feel like they're getting more requests for first-line GLP-1 and SGLT2s from the American prescribing community. Maybe not endocrinologists, but I wouldn't be surprised.
So this has to do, I think, with the cardiovascular prevention. And the more we get data, we know that oral sema right now is sitting at the FDA with the injectable to see if they get cardiovascular indication. We know dulaglutide is also sitting to see if they get primary versus secondary prevention. I think, but they stated it clearly. I think the European Society, they stated that first line is metformin. If you have moderate risk for cardiovascular disease, anything higher than that, or CVD, you start with the other one. I think we have to start also looking at it at the burden of the physician and the patient. Right now, I think when I meet with anybody or when we're discussing, we have to tell patient, are you using aspirin to prevent CVD? Are you using PCSK9 on top of statin, on top of ezetimibe, and on top of SGLT2 and GLP-1, all of this to decrease cardiovascular disease? So it's becoming also cumbersome. Are we doing all of that to do primary or secondary prevention? And everybody's trying to go in that direction, but it's a lot. I think to just think about it, that you have to use 7 drugs to decrease cardiovascular disease, has become a little bit too cumbersome, because everything is add-on. The studies show that PCSK9 is add-on statin, and this is add-on metformin and add-on this. So that's why I think moving things up in the guideline take the relief on, like, you don't have to add more drug just to decrease cardiovascular risk, because patients at the end are saying, I don't want an extra pill just for this reason. It became a discussion that we need to have with patients when they are in the room. Like, for me, and I speak of myself, my clinic, I have it's called cardiometabolic clinic. So patient come, I start talking about everything, and of course I talk about insulin adjustment at the end. But while I'm talking, I have to discuss, are you on, because the majority are high risk of CVD, and I have to make sure they are right now on SGLT2 or GLP-1 based on our guidelines. So I think moving things up in the algorithm makes it easier because of one less drug. But I don't know, to take out metformin is going to be tough.
So let's go back to the hypothetical that you raised, which was the possibility of stepping through SGLT2s, or I guess you could always say GLP-1s to get to SGLT2s. So Bonnie, you make an SGLT2, and I want you to just step outside your normal day job and create the most passionate argument for step therapy in which you have to take empagliflozin first, after metformin, before you get a GLP-1. What would the argument be? Hypothetically, what would it be? Why do that?
So I'm going to answer it a little bit differently. I'm not looking at my crystal ball, sorry. I think the data needs to tell us what is the most cost-effective approach to treatment. Many of these drugs have been on the market for a while, and the data exists. The data exists, whether it's through the electronic medical records, through claims data, and mirroring the two to evaluate these diabetes patients and how they've been treated through time and the sequence of treatments, and evaluate what is the most effective based on the outcomes, whatever you want to define those outcomes, if you want to look at the CV outcomes, and what are all of the costs, whether they're inpatient, outpatient, other treatments. So, we talked about some of the treatments that they then also need to take other things with it. So you can't just look at one treatment in a silo in isolation. It is the entire spectrum of how treatments impact the entire healthcare sector. So based on that evaluation, the data can tell you the stepwise, given your patient population, which one has the preferential outcomes at what cost.
Well, we've heard, thank you, and we've heard obviously that there are some differences that I'm not going to call them minor, but they are the things like the genitourinary infections, there are things like the nausea, things for which clinicians will want to have the ability to pick one or the other, and patients will want that too. So let me take on the job that I tried to give you. And if I hypothetically were to create the best argument, it would be, at least on the estimated net pricing, the oral SGLT2s are down in the 2000s. If oral sema is priced near its net price estimated that we did, up in the 6,000s, that it would be a brainless move not to have patients for whom there's not a driving clinical reason pick an oral sema over an oral SGLT2 as the first treatment. That's my hypothetical outside the box, ignoring other important features that Todd will tell us about in a second. But I'm giving you the opportunity to drive the nail in deeper if you wish. Why not? And then I'll ask the payers afterwards whether it's something that they're even remotely thinking about, and the clinical experts about whether they would envision a world in which there are patients for whom it's a coin flip between the two. Why not have an insurer ask you to use the cheaper one first? Bonnie?
These insurers will look at their budget impact. I mean, as an economist,
Right.
a lot of times you don't look at anything but the numbers. You look at your pure budget. When you're looking as a payer, and if they have, again, you have to decide, is this the payer who is only looking at prescription benefits or the overall?
Right.
I'll give you the hypothetical that overall it's cheaper to
Okay.
use empagliflozin.
And they factored in all of the
Everything.
parameters of it?
Everything. No brainer, right?
If it-
Todd, why not?
I didn't come out and say that.
I know you did. I know.
I was
You said us together for a reason. No, earlier, Joanna was talking about that, I know we want to debate one versus the other here, and I can't believe I'm at an ICER panel saying if cost and access wasn't an issue, which that's why we're here, it is an issue, but the clinicians really want to use them both together when they can, because you're talking about likely different mechanisms to affect the CV outcomes. You're talking about different effects on weight and other things. So it's an attractive combination. Now, with that said, I mean, the SGLT2s were the first to have any data on CV benefit. They've got heart failure. They're good. It's a good class of drugs. What I would say is that data comes in high-risk patients. And so when you look at diabetes patients across the board, A1C is still very important. Meeting your A1C targets is still, I mean, it's what we had to do the registry trials for the Pioneer program, is A1C is the primary endpoint. So if you're meeting an A1C target, whether you're looking at HEDA scores or not, A1C is going to be very important, and clearly the GLP-1s and in particular semaglutide have more robust data there. And we do have, I think you can see at least similar results from weight. If not, maybe it depends on which study you look at. So all the other things outside of cost, and we're brand new, so we're going to continue to work with the payers there. But that would be my argument, definitely to avoid a step of SGLT2 first versus a GLP-1. And you could go, I really like the answer that you look at what specific outcome you're trying to achieve. If it's a heart failure patient who has, their ejection fraction is an issue, they've got the data. If it's, CV risk, if it's weight primarily, or if it's A1C primarily, that's, I think we would both favor that you have a choice versus having to step through.
All right, so let me step through the clinical experts before I go to the insurers and see what we get. So clinical experts, what do you think? Could you imagine a world in which you would not feel clinically hogtied if an insurer said there are patients for whom the first drug, we're not going to block concomitant use later, but the first drug should be X class instead of Y class. What do you think of that?
So I have to come back again to my point on what is my next treatment after metformin.
Right.
And I'm really thinking for what is the benefit of the patient. And SGLT2, they are a great drug. Of course, oral, easy, minor side effects. Some people don't like it. But when I'm thinking, what am I preventing in the long term for this patient? Okay, they have all the benefit. But when I'm thinking, let's just put right now cardiovascular, and I'll talk about others. But if we're talking about heart failure, first of all, I'm not preventing atherosclerosis. I don't think I'm preventing any atherosclerosis with these patients. Second, am I preventing new onset heart failure or preventing hospitalization for people who already have heart failure with SGLT2 inhibitors? So all of this play in my mind. I'm like, if I'm adding this, beside a little bit of A1C, what am I adding additional benefit? When I think about GLP-1, on the other hand, I'm thinking about blood pressure, weight, robust A1C, and I'm thinking also about possibly, hopefully, primary prevention of CVD and possibly about heart failure with preserved ejection fraction. We don't have data, but I'm thinking about a wider benefit that I can see. That includes the A1C. The only concern that is right now it's playing in my mind is there a higher risk of retinopathy? And we don't know if that's just because of the quick decrease in A1C. That's something because also there's some data that GLP-1 could have protection on the retina as well on some receptors. So I don't know if it's clearly related to A1C reduction. The second is the cost that you're mentioning. But beside that, I mean, of course, and we talked about inconvenience to patient, but I think inconvenience to the patient should not be the barrier similar to insulin. When patients need to go on a drug because they need it, we need to find a way of convincing them and working with them around it. So I think in my mind, the two things that if I have to pick, I really don't want to see which one goes first, but if I have to see which one goes first, I have to decide what is more important on the cardiometabolic outcome level, on the microvascular outcome level, on the A1C, and that's how I'll make my decision. If we know that GLP-1 is more powerful for A1C and I can really add one drug to this patient, I don't want to go through SGLT2 and then a few months later add another drug. If I really
just jump on real quickly, because I actually want to circle back to David too, in terms of how primary care docs will think about this. Because the very finely nuanced clinical decisions that you just described may not percolate down to the primary care level. But is there a role for starting patients on both at the same time after metformin? Is that something that the guidelines call for, or do they not call for one and then another if you need it? I would think you would try one first.
They don't say it this way. I think they leave it up to our interpretation. They don't say it that way because a lot of time actually things come together. People have had a stroke and they are all at high risk for heart failure, so you can end up with both. With the data on kidney, I forgot to mention the benefit of EGFR, also worsening of the nephropathy, which is also a big thing. So I forgot that might play a big role in starting SGLT2 as well. So I think a lot of time you have to think both at the same time. I don't think that one should be before the other, but I think because you were pushing too hard, which one should go first. But as a primary care, I think after metformin, I don't see why if both are cheap, they can go at the same time and complement each other.
Okay. Lisa, what do you think?
Yeah, I'll just try and be brief, but I think stepping back, I think the reason for in diabetes, the guidelines are metformin and then everything else. And at other times, people tried to push forward one drug or the other, is because they all have pluses and minuses, and there hasn't been a clear winner other than an A1C lowering. So I think, and again, it's been very political. There was a guideline that came out, and the people who wrote it got just attacked. So by pharma and other things. So, but I think now we're entering into a new era where we have data on these are really beneficial for the kidneys, these are really beneficial in secondary prevention, and I think guidelines, whether they're by health systems or by the pharmacy plans, can help guide primary care providers through that complex decision making. Does your patient have cardiovascular disease? This is then the drug for them that we will approve for. Maybe we'll get primary prevention data, but we don't have that yet. And so until we have primary prevention data for cardiovascular disease, these aren't beneficial. Does your patient have CHF? So a well-written guideline makes those subtleties happen because it's the path of least resistance for the provider for what the next agent is. So I would advocate now that we have more information, we want to design those guidelines so that it is good for the primary care provider. And for example, and I wasn't going to talk about this, but in the San Francisco Health Network, which is not the San Francisco Health Plan, which is our managed Medi-Cal plan, but is our San Francisco internal insurance that people in the city have. It's mostly undocumented folks now. We did not want to include a DPP-4 inhibitor, and our formulary person pushed back a little bit, but we said the data, it doesn't lower A1C and it has absolutely no other benefit. And so we put a clause in that if your A1C is within 0.8 or 0.5 of goal, then you can get it, because otherwise you're doing a disservice to the patient because you're never going to get there. And I sat on the formulary committee for the managed Medi-Cal plan. I don't think I can talk about the details, but the percent of their budget that went to DPP-4 inhibitors in terms of their oral diabetes medication budget, I will just say was huge. And our formulary manager looked at us, because she was also asked to be on that, and was kind of like, thank you, like, because this is what would have happened. And again, I think that's a guideline that we put in place that directed primary care providers to only use it in the instance where it was really going to be helpful, rather than, well, it's easier than insulin, so let me put this on and wait another 2 years with a high A1C. So in that line, I think you can guide people with good pharmacy benefit guidelines that give people the best benefit.
So let me, before I turn to the insurers again, David, how are you hearing this and trying to think not just of the primary care doctors that you work with at an academic medical center, but more broadly? What do you think is going to happen?
Yeah, I want to step to one other thing first, and then I'll answer
More
that.
steps. Okay.
Yeah, right. One is just on the question of the SGLT2s and atherosclerosis, at least in the empagliflozin trials, the reduction in non-fatal MI looked just like the reduction in MACE in terms of the percentage reduction. So I guess I'm not sure that it's not doing something on atherosclerotic events.
It was not significant.
It was 0.87 versus 0.86. Of course, they had fewer numbers, but you know, the fact that it wasn't statistically significant doesn't lead me to think that it wasn't real, is all I'm saying on that. So I think it does have probably CAD event reduction, but maybe not. In terms of primary care doctors, I'm not sure that I have a good feel for this. I've watched how many people are getting DPP-4s, but in my academic swirl, like Lisa, there's been this sense that we're not accomplishing a lot with those drugs, and so I'm not seeing them used a lot. I'm seeing a lot of hesitation around SGLT2s because of this sense that if we're giving a drug for prevention, it's mildly nerve-wracking to give drugs that have bad risk for harm. And so that's caused hesitation to use these drugs, whereas a drug that causes side effects but not risk for harm is less scary. We give a lot of drugs that cause side effects and that people say, I won't take anymore. We're way more willing to do that than have somebody come back having their leg amputated because it turned out that the drug boosted the risk of amputation. That's way scarier for a non-specialist.
Okay.
I
So
think this is a great point that we as physicians...
can you grab the mic?
I just want to agree that as physicians, when we try to also practice some sort of defensive medicine, we don't want to cause harm. So it's okay to discuss side effects with the patient, let them not tolerate and have the choice of refusing going on a drug rather than worrying about causing harm.
So Jeff or Bill, when we look at the numbers that, again, ICER estimated on the net price for the oral SGLT2s, it was $2,500. I've got the numbers over there. I'll just make it up. 2,000. It was in the 2000s. Oral semaglutide was with a 35% discount off the announced list price. It will be $6,100. At what point does that difference grow to a point where you think payers in this country will start to think seriously about some form of stepping from the lower cost to the higher cost? When guidelines say it's kind of any of these depending upon your clinical judgment. What do you think is going to happen in the weighing of this now that we have an oral drug that is, at least again, to our estimate, going to be priced much higher than the other oral drugs that are on offer?
I think to start, the reason why we haven't seen too much step therapy in diabetes to date is because the SGLT2s and the DPP4s have been relatively inexpensive. The GLP-1s at $10,000 minus rebate are expensive, but there's been a built-in step. Mm-hmm. The payers didn't need to do it. The injectable created a invisible barrier there, so the GLP-1s haven't been utilized to a great degree. What's changed now, when we get Rybelsus launch, is that may change. So I think the payers now are forced to look at the diabetic category, oral category, and potentially make changes. So I mentioned one payer that potentially does a GLP-1 injectable step before Rybelsus.
Right.
So it does allow them, so it doesn't take the GLP-1 mechanism of action out of their hands. It just allows them to keep doing what they've been doing. Open to get up to the oral side, then you get to reality in dollars and cents, and I think that's what they're concerned about right now.
Do any payers have provider restrictions on the GLP-1s? Can they be prescribed by primary care docs? Do any of the payers say?
I have not seen any specialist requirement.
Do you guys know if there are any specialty? You would know this. Are there any specialty requirements? Because that's another way. If they want to restrict the use for oral semaglutide on a cost basis, they could require specialty or in consultation with a specialist.
But then you're forcing people to a higher cost physician.
Correct. Correct. All right, Bill, what do you think Medicaid, and any perspective on this from your?
Well, yes, from our perspective, when this kind of stuff happens, the hat I wear, I perceive this whole conversation as being there's a new drug in town, and it, from all the metrics we looked at earlier today, it looks like it's comparable in many areas to the existing drugs on the market, but it costs more. And so if we want to sell this to the Medicaid program, I usually go back to the medical director. We did this with the Hep C drugs, and we'll, but we ask ourselves, is there evidence? I liked your discussion about a niche. Is there a niche for this drug? Are there people who have diabetes or have this condition that need this on the formulary? Does this need to be on the formulary, or can people in our network be treated with existing drugs? If they can be treated with existing drugs that cost cheaper, we're going to go with the existing drugs that cost cheaper. But there's got to be a niche. There's got to be some kind of argument that not everybody can use the cheaper drugs that we have, and that there's a more expensive drug out on the market that needs to be available to people in certain conditions. And then once we've gotten to that point, we can start coming up with a formulary, with a step, with a clinical guideline that says, yes, we're going to put this drug in the market and it's going to be available to there. But I don't think it's very likely that we're going to take a drug, we're going to encourage use of a drug that costs $4,000 a year more if there's no niche for it. And I'm not saying there is or there isn't, and I'm not a diabetic physician, so I mean, this is the kind of thing that we would have to have deeper discussions. But I think the utility of this kind of meeting for us is, okay, there's a new drug on the market. It seems to have some benefit. It might have some benefit for some people. Is it something we need to consider? Does it need to be in our formulary to be sure that our members are receiving adequate care for diabetes, or are we missing somebody?
So,
yeah, I've heard
can I pose a question
yes,
here?
actually, and I just want to echo, because I've heard, just to be clear, this is not Rhode Island specific. I've listened to a lot of insurers. Medicaid is not unique in asking the questions that way. Is there a need for this in the formulary? If it's more expensive, what is the need? And I could imagine some hard conversations about, we have oral treatments for this. If they have to have a GLP-1, there's an injectable. If this isn't a lot less expensive than the injectable, then what are we doing? Why do we need this on the formulary? We might drive patients away from the oral SGLT2s towards the oral GLP. I can imagine all of this happening behind closed doors in rooms across the country as people are trying to sort this out. So it's going to be a very interesting next few months, I think. Todd?
Yeah, so the question I have, I guess, for these and others is that for the sake of the ICER work here, obviously we've used the comparators that were from the Pioneer program, other oral agents, and liraglutide. But is the more relevant comparison that a PBM or formulary is going to look at is, this is a GLP-1. And when you do that, you know, the discussions of, we have this more expensive agent, it's not more expensive. So if you're talking about fitting it in your class of GLP-1s that you're going to offer and deciding between those, I think that changes the argument considerably versus comparing to agents that have been out for a while that are cheaper. So I think, you know.
Do you think it depends? I think it depends partly on whether people are envisioning this as it's hardwired in the clinical community, primary care community, whether a patient will get an SGLT2 or a GLP-1. That's hardwired. And we're just giving you another option, equally priced, easier to take for the GLP-1s. Or whether there's really some decision making, and if I'm a payer, I'm more worried in some sense about not getting any added extra health benefit for patients peeling off to a more expensive option. If I'm a clinician, I love having, in patients, there's no, you know, it's not as big a deal. So I think it in some ways will reflect back on whether people are viewing this as a have-to-have on the formulary, because we're going to have patients who need to take GLP-1s, and this is a better option for many of them, or something like that. Is that a fair?
Yeah, it is. And I think, you know, you look at daily versus weekly GLP-1s, and that there's a whole, we're having all of these discussions now, obviously, with the payers and where it fits. But I think we talk to payers, obviously, every day, and the frustration is adding on a second or a third oral, and nothing gets better. You know, the A1Cs don't move, maybe outcomes aren't there. So that's where they want help, and that's where we're trying to offer that, you know, perhaps we can, with SGLT2s alongside, you know, move these more effective therapies up where they are going to make a difference, and maybe get on board earlier so they can see that. So that's where. And
are the European, let's say you're in a developing European country, take whatever you make out of that, a lower income European country. Are they just saying, the hell with all this, just use insulin? I mean, I'm sorry, I know you don't like it, but we can't go with all these higher priced add-on 3-4 pills. Just go to insulin because our economy, our budget can't support that much add-on multi-therapy treatment when there's a cheaper single option available. I'm sure in Europe we're not having...
Sure, it's a different environment.
It's a different environment.
We're way ahead of the curve in regards to access to the newer
I'm not
therapies,
suggesting
so
that's the way that the U.S. should go. I'm just saying I'm sure that's happening. I need to be sensitive because I want to give you all the chance to say really quick things. And first...
No, just saying that we can see that already, like the guidelines, IDF or WHO, they left GLP-1 off their algorithm anyway.
Interesting.
And I just wanted to make a comment about the rebate, because
yes, I was going to...
With Medicaid, we get when we crank these numbers with our rebate, they might look different for the Medicaid program.
That's right. Can we have a meeting about diabetes and not talk about rebates? It's hard to believe we almost did that. We're not going to have the time to sort the problem, to fix it, but I feel like on behalf of the patients of this country, many of whom have been part now of programs and initiatives to come to Washington even to do everything they can to say that the cost, the out-of-pocket cost to insulin, which is often, and to other treatments, which are often linked to the list price, not the net price, is really a crippling financial burden for too many families. And we don't have the panel here and the time with which we should try to lay out an agenda for how to fix that. But I just personally, I feel like we shouldn't have a CEPAC meeting without recognizing that the current structure in which the list price continues to escalate while the rebates are enormous. We're talking about 35, 50 and more % rebates. Patients don't always see that, and there are lots of problems with that. So I think we all would share the sense that if we could probably throw one switch to help patients today in terms of the financial burdens, it would be to address the effect of list price gross to net bubble and their out-of-pocket commitments. Anybody want to? If you want to throw in a zinger on that, feel free to, but it'll be part of our final message because it's got to be something that the policymakers take very, very seriously. I want to also say that what I want to do is to give each of you, and I know there are, 8 of you, a minute to give a final kind of statement. And with that statement, I really want to encourage you to identify what you think is the most important take-home message that you want captured in the report, and or the opportunity to make, I sometimes phrase it as a request. If you could ask one thing of any of the stakeholders around the table to do differently, that you think would have the best impact on the way that patients are cared for to reach that 3-part goal of fair price, fair access, and future innovation, make that request now and we'll capture it for the record. So with one sentence and a comma as part of it, let me see what we can get. And I like to let the patient think most on this. So I'll start at this end of the table and come down. So concluding thought or a kind of a request with a kind of, that's what you think should be most important. Right. Bill.
Okay, so I've been associated with CEPAC for quite a long time. And I always say that I jokingly say, I don't care what your results are. You're asking the right questions and you're addressing the right issues, and the specific recommendations that we make are less important to me than the fact that we're having the right discussions and we're addressing the right issues that need to be resolved. My request to the people here, though, would be that, especially the clinicals, if there is a treatment or a treatment that you think needs to be included in a formulary or as a benefit package, we've got to work together more closely and be able to define that niche for that product, and articulate it, and then communicate that to the payers.
Thank you very much. Jeff?
So leading up to the introduction of the drug, when everybody was wondering about the price, we had several meetings at our organization trying to, hypothetically go through scenarios on where was the drug going to come in at price. And we ultimately agreed that it was going to come in exactly where it was, because any amount less is kind of leaving money on the table. But I think pie in the sky, coming at a lower price, could have been a different theory and capture the market. So let's say it came in at 6,000 or 7, we might have been having a different conversation. But being that the price differential is so huge, I think we're stuck with talking about step therapy and things like that. So pie in the sky would have been a lower intro price.
Okay. Dave?
So quickly, sitagliptin's been an important treatment option for over a decade now, treated millions of patients in a safe and effective way, and I think it'll continue to be an important element of the treatment pathway. One request, so this is an and, I know you asked for an or, would be to look at treatment combinations to get a more holistic view on trade-offs for treatments in this important disease area.
Thank you very much. You guys are using and very strategically to get your one sentence. I've been impressed. I've been impressed with that so far. Bonnie?
So the one takeaway, I think, and at first I do want to say I really appreciate all the efforts that University of Washington did. I mean, this was quite a task. So I do appreciate what they did. The one take home I would say is that I really do believe that these long-term studies need to speak volumes to the treatment. You're not talking about treating a patient for a short period of time. They're going to be staying on this treatment. And those long-term studies are really what's going to drive what are those outcomes at the end of the day that we need to gear toward treating these patients. So that,
thank you.
But the other thing that no, you said two things to request differently. Oh, please.
Be really quick,
Real
please,
quickly.
please.
So what I really think I should look at doing is look forward in a few years when the data for oral sema is out and do that database, the EMR evaluation, and really see what were the findings based on what came out from the report.
Real world evidence follow-up. Got it. Todd?
I think she read my notes here.
I did.
Okay.
So,
Lisa, no.
Again, I think I want to stress that I, as a clinician and part of Novo Nordisk, I'm hopeful that more patients can benefit from effective GLP-1 therapy that are not available and getting it now. And I agree with my colleague that I'd love to come back and reconvene when we have the massive outcomes data that we're going to generate over the coming years with over 9,000 patient CV outcomes trial, over 3,000 in renal trial with injectable sema, and then 15,000 in a obesity-related semaglutide dosing. So let's open the books up when that data's here and see how it changes things.
All right. Quick answer is yes.
Yes.
We will revisit this as time goes forward. Lisa?
Yeah, a point I'll make, since you brought up Europe and their archaic ways of medication use, is just in California, I think the only entity to meet its HEDIS measures is Northern California, Kaiser, all of them, and they use metformin, sulfonylurea, and insulin, and that's what they use. So it's not the magic of the medication per se in terms of lowering A1C. It's the systems that you have in place and the education you have for patients. And so the provocative thought I'll throw out is maybe we need to think of these new drugs more as cardiovascular drugs and renal drugs, right? Because we have very few things that are super effective for patients with established cardiovascular disease and diabetes, and the GLP-1 analogs and the SGLT2 inhibitors are, and that's really been missing. And same for end-stage renal disease and late renal disease, where especially the SGLT2 inhibitors are useful. So maybe we give them to the nephrologists and the cardiologists, and the endocrinologists keep using things that lower A1C well.
Okay, thank you. Joanna?
I think as a clinician, I would say there is no better time to be practicing, to have all those options to offer to patients. It's more exciting, or it's even more important that patients have all those options that they didn't have before. And since we're talking about oral sema, I think this is a wonderful opportunity for patients to have a pill that helps them for weight loss. In addition, we're talking about type 2 diabetes, because in the past they needed to go on a pill, an injection or pill that is not approved by insurance and going through so much hassle to get them to lose the weight in addition to all those benefits. So having an oral GLP-1, I think at this point is just something that we should try to make the best out of it if we can use it to our patient. I don't deal with how we can get this covered. It's expensive because of bioavailability and so many things, manufacturing and so on. Hopefully they'll come up with better molecules in the next couple years. But what I'd like to see is being able to see how those GLP-1 and SGLT2 work together and see if we can offer them to all the patients. I don't think it's my job as a clinician to think why it's not cheap. I let the other people worry about this part. I think for me as a clinician, I'd like to be able to offer them to the patients and both of them if I can, because because of all the benefit that we discussed. It's about the A1C and all the additional benefit that they didn't have before.
Okay, thanks. Susan, final lesson.
Mine was, what is the request, right? So my request would be that we not call a person a diabetic, but rather a person with diabetes, as they are not defined by their condition, but it is part of who they are. So they are a person with diabetes as part of their overall being, and that will lead us to further collaborate with people who have type 2 diabetes, who are the main experts in their own care, offering them options, accessibility, and reduce cost to improve outcomes.
Thank you. You have more than a second left on that. No, thank you for keeping our view on that level as we close it out. I'm going to have the CEPAC go around and make final comments, but before we do that, I'd like to thank the Policy Roundtable for its contributions. As always, it's been incredibly important for the overall process of our meeting, and many of the things that you've talked about during this Policy Roundtable will be very important as decision makers read our final report. So thank you very much. So CEPAC, the same challenge in a sentence. Final reflections, things that you think are important for us to take away from this meeting and capture in the report. We'll start with Jason at this end.
There's so many people with diabetes in the United States. The aggregate mortality and morbidity is very high. We have efficacious therapies, diet and exercise, the older medications that are also efficacious, and these newer, more expensive, efficacious medications. Just I would call out for more strategies to address underutilization of these treatments. Diet and exercise has to be in ways that works for the patients, but also the medicines, as has been referenced, and there's some broad academic literature on this, are underutilized. So comparative effectiveness strategies about how to actually deploy the strategies in efficacious ways that work for patients' lives.
Great, thank you. Stephanie.
Thank you. I will have a compound sentence. I'll do my best. So I think I resonated, or what Jason said earlier really resonated with me with regard to needing to look at society, and I drew a lot of parallels with patients with psychiatric disorders and substance use disorders, and the way that society is built that is not, it's sort of almost promoting some of these diseases, so or semicolon, even though it's not really. Secondly, I have my stigma-free sticker. I love it. You really made me think about the term adherence. So I'm already on board with not using non-compliance, but that really also resonated with me, so thank you. And finally, there, I think, is an opportunity as well to engage pharmacists as medication teachers in clinical practice sites, particularly maybe in primary care as well. So those are my three.
Thank you very much. Steve.
Great, thanks. We've considered value looking at a threshold of how much we're willing to pay for an additional quality. And there's another trade-off that we can consider, is that how much health gain are we willing to leave on the table for a lower cost? And I think that's an issue for many patients who are exposed to higher co-insurance, co-pays, and higher prices of medications that are just not affordable. So I just want to throw that perspective out there too. There may be a patient for whom glipizide and pioglitazone is working, and that's what they can afford. I have the iPhone 6, not the 10. That's what I can afford. So just another perspective that maybe we didn't get into too much, but just throw that out there as well.
Okay, thanks. Ed?
I'd like to thank the folks from the University of Washington for making the model so understandable. I agree. I think it's the best anybody's done with that. It was an excellent model. I used to say that we had, for diabetes, drugs that were 50 years old and we don't really need anything else. I think I'm convinced that we do need some of the newer drugs. And I look forward to using oral semaglutide. I have some patients in mind that I'll talk to them about it the next time I see them.
Good. Jason?
Echo my colleagues' comments. Thanks to everyone who made the meeting so informative and effective. Can always take away that we need more evidence, right? That will never change no matter the topic, that more evidence would be incredibly valuable. But what I am left with is I'm convinced that based on everything we know and we've heard about the complexity of the disease and its manifestation, the complexity of treatment regimens, not just the pharmaceuticals that we focused on, but other approaches, and the complexity of individual and combination therapies within class and between classes, this strikes me as a topic and a disease for which, even with all the evidence that we hope to have and will continue to get, clinical judgment, individual judgments from primary care providers and specialists will remain particularly vital to managing the unique presentations of diabetes, and to the extent that clinical guidelines or rigid formularies unduly may restrict the kinds of flexibility that I'm convinced that providers need, I think that's something we need to be attuned for. Evidence is valuable, but flexibility here seems particularly important to thinking about the heterogeneity of this disease and how we treat it.
Thank you very much. Martha?
I want to go back to the idea that 25% of patients ask for cheaper drugs and 13% forego drugs. And I'm thinking that those are the same patients who typically can't afford the foods that would be most useful for controlling and don't have the time for the exercise because they're often working 2 jobs. So, you know, it's the same refrain for me over and over again. I want people to be sensitive to price and really think carefully about when they produce something that is useful. And clearly we've heard a lot of very, encouraging data here that they need to think about how much profit they need to make.
Thank you. Greg?
There's something strange that I think orals are cheaper, right? Usually they're cheaper, and it's this strange thing that I'm being told this is a great deal because it's the same price, and it seems strange. I would think the oral's going to get a bigger market share, and so I think Jeff brought up the point of there was a road not taken here, and that's too bad.
Thank you very much. Brian?
Yeah, I think my eyes have been opened a bit to the complexity of care. The children and adults with cystic fibrosis I take care of, the burden of care is enormous. I think that's an issue here, and simplifying care is got to be a goal rather than adding on another pill and another pill and another pill. And I also want to just echo what Jason brought up, that maybe the candy and sugar companies should be paying the drug companies for all these expensive medications because it's their problem, their fault.
Thank you. Left there, yes?
It was a very fruitful day, and thanks. I'm leaving this reminded of the angst of patients with diabetes. I would like this to be very evident. It's one disease that affects every moment of people's lives, what they eat, when they wake up, if they're going to have hypoglycemia, when they're going to travel, how they're going to travel, what they're going to have with them, if they can go to a social function, even before complications arise. Essentially, what we're dealing with here is a very fluid disease with no real cascade. There was a cascade that and a stopgap that was there because of the needle that really stopped the GLPs from being used. Now this has been removed. So essentially what is the response of payers is trying to create another way, either putting the needle back again, that we have to go to the injectable and then go to the oral, or some other stops. I think that system is not the way it should function in a society that wants to help people with disease, trying to prevent people from using a resource or trying to, as somebody up there mentioned before, not leave a penny on the table. I think that it should be done in a better way. There must be a better way.
Thank you very much. Leslie.
First of all, I want to thank everyone for their work. University of Washington, your modeling work was fantastic, and we really appreciate your efforts in explaining everything. There are 2 points really I've been thinking about. I came into the meeting thinking, well, this is pretty straight. This is going to be pretty straightforward, and I'm always surprised at just the wonderful work, but the amazing contributions and spending time with folks who help us to understand the complexities of these diseases. I spent a lot of time in rural South Carolina, and so I think that someone had maybe brought this up, and it might have been you, Steve, in terms of being mindful about the patients that might not be at the table who reflect some of those very complications and microvascular complications. I'm mindful of being in the low country of South Carolina where the number of dialysis centers are great, and a lot of that has to do with just not being able to care for their diabetes and not being able to afford medications and getting the care that they need. So there's that. But also just trying to be mindful that there probably are so many patients that we don't even know who are on those medications but simply can't afford them, and how they're not able to take the appropriate treatments and therapies to keep their blood sugars down and decrease the complications from micro and macrovascular complications. Thank you.
Thanks. Claudio?
I want to thank Susan for bringing forward Monet's story, because I think it really reminds us that not all patient circumstances are the same. And one of the ways we honor that great phrase of patients being the experts of their own care is by making sure there are affordable, accessible options. And let the trade-offs be made by the patient depending on their circumstances. So I appreciate that, and I thank you for bringing that to our attention.
Thanks. Rob?
Thanks. And this is maybe the 6th or 7th meeting I've put my public health hat on at the end and said prevention. I know that patients benefit tremendously by treatments for these diseases, but they would benefit even more if they didn't have the disease in the first place. We are now spending $4 trillion on a healthcare system organized around treatment. It would be great if we could organize well around prevention, because that's fundamentally the best outcome.
Thanks. So I just had 3 brief things to say, one which we'll catch with many of the others that people have said. One is we've actually failed to acknowledge and, in a sense, thank the companies and others who contributed to creating head-to-head data for drugs that I know we have relatively short-term data on the cardiovascular outcomes, but this is happening within a system that we don't always see, which are good head-to-head active comparator trials. So that should be appreciated and rewarded in different ways. 2 is something that Lisa said that I also, as a former kind of practicing primary care doctor, we do underestimate not only prevention, but the systemness of the care that's required to create a good care network for patients with a chronic condition like diabetes. And I'm not surprised that the best outcomes honestly come from systems, integrated systems like that. And we need to think more about the kinds of delivery system innovations and not just sprinkling the next new drug on top of a system that's dysfunctional from many different directions. And lastly, this issue of this is, I don't know what would have happened if, in 1928 or whatever it was that Banting invented, or just 22, I'm sure. So I knew somebody else would know this at this table. So we're not that far off from 100 years. It's unclear what would have happened if at some point we had a Manhattan Project and funneled all national resources into a centralized program to address and maybe cure, who knows what, to do something with diabetes. Instead, we've let, in a sense, a kind of free market approach evolve. And it's had many successes. It's had a lot of new treatments come out, and I'm not sure how many we would have had if we'd done it differently. But it feels like we're just continuing to do the same thing now. As the number of patients who have type 2 diabetes continues to increase, we continue to create new drugs, but it just doesn't feel like we're breaking a habit, if you will, or almost a pattern. So we need to keep doing what we're doing better, but I do wish that there was some appetite for something that would really break the mold, whether it's a kind of outcomes or capitated approach where the federal government would call together all manufacturers in the diabetes space and say, we're going to give you the same amount of money that we're giving you now for your drugs for the next 10 years. But it's all dependent, and you can use it any way you want to. You don't have to even present, you don't have to make a single pill, but you have to improve the outcomes for patients. And that might mean a lot more prevention. It might mean, when I lived in England for a year, their diabetes program starts with educating new immigrants to England on how to buy groceries in the supermarket to help, from people who don't know the English food, how to buy healthy food to create a better family meal. That was actually housed in this kind of loose public health diabetes kind of. So we need to break the bonds of our silos and to figure out what to do, because we're going to have meetings on NASH drugs, on other things. I remember when ICER did a meeting on obesity maybe 8-10 years ago. And it's still out there. There was a medical device that basically was a tap that's put into the stomach, and you open it to offload the stomach contents. And it felt like, really? Is that really where we're headed with treatment for obesity? So GLP-1s are great. Anything that patients can do to improve their health now and in the future is great. But I hope that there's innovation in a big way in other facets of how we care for patients, including involving them and moving towards some of these different models. So thank you to the ICER and UW research team. Thanks to the logistics folks, to the CEPAC, and to all of you. We will, the meeting recording of this is going to be posted to our website in about a week, for those of you who really want to witness it again. And the final report will be out on or around December 9th in time for the holidays. Thank you again. We will be revisiting diabetes as time goes on. Thank you for the participation, and safe travels home.